Alrighty, there we go. Welcome to another episode of the Doctors and Dollars podcast, where we discuss health insights and wealth secrets. I'm your host, Nate Crannell, joined today by Dr. Syed Abbas Moosavi. Dr. Moosavi is board certified in physical medicine and rehabilitation, working as a primary provider at Macomb Pain Management in the Detroit Metro. His special interests include the management of spine, musculoskeletal, bone, joint pain, and sports injury. Dr. Moosavi also specializes in neurological disorder pain and the rehabilitation of such disorders. Aside from his time at Macomb, he is also a lecturer, a VES examiner, and an orthobiologics specialist. Welcome to the show, Dr. Moosavi.
Thanks for having me, Nate. Appreciate it.
What is going well today?
A busy day, a nice end to a busy day, which I appreciate. It's always nice to have that good ending. So,
yeah, define a busy day for me. Is it 10 patients? Is it 30 patients? How many people are you seeing on a busy day?
Today, lectured at Henry Ford College. Came over,
Nice.
did a couple of VES veteran examinations, which I enjoy doing, and did some injections, did some EMGs, did some evals, did some orthobiologic evals. So I had a very, very diverse mixed day today. I saw patients from 2 or 3 and maybe actually up to 4 or 5 different service lines that we have in our office. So that's, and lectured and sitting with you now. So
and lectured, man, a diverse day, which is perfect because I want today's theme of our conversation to be diversification. Many people know about portfolio diversification or stock diversification. That's what I used to do in a past life. But one thing I know about you is that you strive for income diversification, creating several revenue streams, having different arms, different hands in different cookie jars, right? So that when there are lulls or downtimes in one specialty, there may be, other streams of income that are amplified because of the reason for that lull. And so talk to me about why that is so important to you, why that is something where you probably focused on one specialty to start your career, and how you have diversified over your career to create so many revenue streams.
So exactly what I did in 2010 when I started practicing. It was primarily interventional pain. So I did that 100% of the time exclusively. I did some EMG, some nerve testing, etc., as a part of our specialty background. And as the years went on, started understanding and realizing there's more to my specialty and my skill set, and not just focus on interventional pain. And so probably in the last 2 years, I've been really diversifying my own patient referral source and stream, as well as the services we render and offer through our offices. And I do that. Yes, it's nice to have not putting your eggs in one basket type of approach. But I think the biggest thing for me is I find that when I diversify, and I have been diversifying, it's definitely stability from a financial point of view, because obviously we have overhead, we have different ways we have to pay for our daily expenses, but it also increases interest in the practice. When other referring physicians, other providers, other clinics, other organizations see what we're doing, I find that they're intrigued by it, and they almost have more interest in what we have to offer. And it's been like that for the last couple of years. And as I mentioned today, within the same day, I did my orthobiologics consults, the new ones. I did my veteran examinations or evaluations, we call them. I did EMGs, nerve testing. I did a few epidurals, injections. I did some traditional pain evaluations, new patients. So it's a nice diverse group of patients, and everyone has a slightly different treatment plan. So you have to kind of wear multiple hats as you see the patients, but I think it's a really nice way to spend a day. Yes, there are some days where we do more of one type of service than others, but in the end, I think it's much more beneficial from a practice owner / practice growth perspective that we offer diverse lines, not just in patient care, but outside of that, different services that we can offer that that can be helpful to a patient because it's convenient. It's kind of everything under one roof. But then, it would have been income that we would have just sent out to, some other
Sure.
organization that we can keep, and, service the patient, and they're happy, and, and we have some level of revenue that helps maintain that service. So,
Yeah, there's a lot there. That was really good.
yeah.
The one thing I think of is, if you didn't offer those different lines or have those different offerings, you would be sourcing those out. You would be referring those to others as potential lost revenue, for you guys.
Correct.
Do you feel like having those multiple lines or those multiple offerings, does that keep you on your toes and allows you to work at a more heightened state? Or do you feel like that you're opening yourself up to more chances for overwhelming and putting too much workload on you and everyone in your practice?
So, very good questions. And we've had actually a couple of conversations with my office manager specifically about this just today. So, for me personally, our job, there's a lot of monotony in our job, right? Repetitive, even when I do my epidurals, so it's nice to be able to have a different type of patient every third or fourth patient. That's not your traditional pain. That's not your traditional orthobiologic. That's not your traditional veteran. That's, an auto. I also do auto workman's comp too. I didn't see any today, but I do that as well. So that's another kind of a diversifying service line. From an internal structure perspective, it's a very it has to be a calculated, well thought out plan. And so in our organization, we have everyone knows how to do pretty much everything. Meaning, if I get a referral from a veterans office or veteran, everyone knows where that patient fits into the formula for my day. But there's one person that handles that direct communication. When I do my orthobiologics, again, everyone knows, okay, orthobiologics are scheduled like this, et cetera, but there's one person that handles the administrative aspect of the orthobiologics. So every service line that we have, there's one go-to person in our office that is the primary person that keeps in touch for scheduling, for referrals, for intake, but everyone knows how to do it. And this is where my manager and I were just conversing today, is because she joined our practice a few weeks ago, and I've known her for a decade, but and she knows kind of how I work. And so we had that conversation about, okay, so we don't want to overwhelm the staff, but at the same time, we don't want to lose that service line or that, efficiency of offering that service line or that different type of patient that comes into the practice. So as much as it's important for us to offer it, I think it's equally, if not more important, internally to be able to manage it, and we're doing a pretty decent job. I mean, I think we have a reasonable infrastructure in the organization. Absolutely, more staff is always nice, but more staff costs more money, and at some point justification for that can happen. But for now, we're running at pretty decent capacity. But yeah, so that's the answer to that question. Is yes, it can get complicated, but I think if it's done right. And we have separate meetings for separate service lines, different meetings for different things. I don't sit down and, we don't have our, staff meetings and we talk about 20 different things, because that'll just, instead we talk about, okay, guys, this is what we're going to do. This is our, our orthobiologics meeting. And this is what we're going to talk about. We're going to talk about our veterans, our traditional pain, our, our auto, our workman's comp, et cetera, et cetera. So that's typically how we handle it, is that we have to really internally organize ourselves.
That's a really good way. I mean, you have a quote unquote a scheduler or some type of organization assistant in each line, but then you have what I would call like an administrative manager that kind of oversees all and makes sure that, scheduling doesn't conflict. You're not doing too much or sending you to one side of the town, and all of a sudden you got to turn around and be back on the other side of town, 10 minutes later because of poor scheduling. So I think that's really good. And just to clarify, I mean, everything's under that PM&R umbrella, right? So it's not like you're out doing neurosurgery or lymphatic something, all these different things. It's all still within PM&R. What drove you to do PM&R? I mean, there's 1,000 different directions you can go when you go to medical school. What drove you to pain management and rehabilitation?
So I can tell you, originally I had a very strong interest in radiology. I mean, that's what this is what I wanted from the day I knew I wanted to become a physician. That's what I said, this is what I'm going to do.
You want to go to school longer than everyone.
Right, exactly. As I got into medical school, you get exposed to different things.
Hmm.
And I went through a number of rotations and exposure to different specialties, and I came across PM&R, pain management, interventional pain, etc.
Hmm.
And it didn't take me long to, I did about three, I think almost three rotations in radiology, and I loved it. But then I did one rotation in this PM&R, where I did still have to interpret, because we do interpret our studies. We look at X-ray guided, X-ray guidance for our injections. So there is some level of, radiologic interpretation involved
Yeah.
there, not to the degree of a radiologist, of course. And I just took a liking to it, and I didn't think I would, but I completely shifted gears. And that was about near the end of third, fourth year of medical school, and that's what brought me to PM&R. I mean, I enjoy the physical element to function improvement, diagnosis, treatment, but then the diversity that you have, right? I mean, because of
Hmm.
PM&R, I'm able to do EMGs, I'm able to do interventional pain, I'm able to do, even some of these veterans I see, I evaluate for traumatic brain evaluation and injury. It's almost like
Hmm.
an independent medical exam. But I do that for vets, and I do TBI, and that's within my scope of practice too. And orthobiologics obviously is, because we inject into joints and spine, and we have to understand the anatomy and so on. So I don't think I could have got the same type of diverse opportunities in doing radiology. Not that I saw this, in the future as me being where I'm at today, but when I think in retrospect, I'm really happy I went into this field, and I wouldn't change it for the world.
For sure. And when you get into PM&R, there's kind of maybe when you had a practice or you were working for a hospital, maybe there was just that singular focus on one specific area. When
Yeah.
do you think within your career, when was that turning point when you're like, man, I do need to create more streams. I do need to have more offerings within my business line to be able to not, outsource that to another person who then captures that revenue from the patient. At what, was that year 2 in your career? Was that just recently? When did that come about?
Like the first 5 to 6 years of my career, I basically worked as a staff physician. So
Hmm.
in that organization, I actually brought many service lines. I brought ideas, different things we can offer for our patients. And I think that's where my interest stemmed. And the reason why that happened is when I joined the practice, I mean, there's a couple of ways the practice is run. You can stay within your four walls and you just manage it, and you work and you see the patients, they come to you, etc. Or you can stay within your four walls 2 days a week, and the remaining 3 days a week you can go and explore. You can work at other organizations, build relationships. So I was the one physician in that practice that primarily was a go-getter, in that I didn't mind doing that. If we wanted to build a relationship with another pain doctor or PM&R that didn't do interventional pain, they would board the interventional pain procedures for me, and I would go do them at his or her office, that kind
Okay.
of.
Yeah.
So that exposed me to what was out there. I think if I didn't do that, I wouldn't understand the diversity that we have available as options. And so for the first 6 years or so, I did that, and then after that, from 17 up until last year, early last year, I was a consultant. So essentially, I went to different offices. I did, I was as a specialist. I did
Hmm.
treatments, interventional treatments, pain treatments, EMGs, nerve testing. And then when I was there, all the doctors and the other staff would be like, "Hey, Dr. Moosavi, do you do this?" I said, "Yes, I do everything that you're asking me to do, but your organization only wants me to do this." And the patients
Hmm.
would come to me and say, "No, I want Dr. Moosavi to do this, et cetera, et cetera." So, we build relationships. So then last year, when we decided to kind of take the plunge and say, you know what, I'm happy with consulting. It does well financially, but there's not much stability without your own brick and mortar. And that's kind of what stimulated me early last year to say, you know what, I'm going to use my connections. I'm going to build my own practice, and not just build my own practice and organization. I'm going to build and diversify and use all these service lines where people have been asking me to help them with, can you do this for me? Can you do that? And, it was a physician that reached out to me, for example, to do VA evaluations, because they didn't have anyone servicing the Michigan area, at least the greater Detroit area, and I'm the only one that does that for that organization, and so on.
Hmm.
So when I had the opportunity, I took it. I mean, and that was from day one. And not only that, from a scaling point of view, I scaled from day one. We have offices in Ypsilanti. We have offices in Grand Rapids. I see patients. We do some work out in Clinton Township, and then Shelby is our main office. And I did that from day one when the opportunities came. And again, they came because someone called me and said, Dr. Moosavi, we need someone to do some evaluations in Ypsilanti for regenerative and for auto. And I said, you know what? I can go out there one day every other week. I can manage that, and we sublease space and so on. So the diversification element of it, I understood from day one, from my practice, because I was exposed to it. But I think I was able to direct and do it and actually implement it early 2022. So my practice, our actual practice, we're taking about a year and a half, maybe a little less than a year and a half. We officially probably were like a July 2022, and we've been growing pretty heavily since. And we have another provider, Dr. Michael Bonnet, that works with us. Great guy, very good clinician, and U of M board certified, trained, et cetera, et cetera. And so right now I manage the diversification. And he manages the traditional pain. But at some point, as we get more providers, as he gets busier and I get busier, we're gonna kind of tag team this and get some more providers on board. But yeah, no, the vision has always been there for me. It's just I needed the platform, and and
yeah,
that's how I did.
That was a great answer. Thanks for sharing that. It sounds like it, just to summarize everything you said, it sounds like it came from a mindset of prosperity, right? Where you were being pulled in different directions because other physicians were like, hey, I need you over here and I need you over here. And you're like, yeah, I'm willing to do that. But now it sounds like it's kind of flipped to where you're going out and you're finding those people and maintaining your network so that there's prosperity. There's not there's not that scarcity mindset of like, oh my gosh, I have to keep everyone in, within my four walls with Macomb. Otherwise I'm losing it all. But being able to offer those different lines, I think is fantastic. And we had talked offline and something that I always preach, that 50% of something is better than 0% of nothing, right? You got to be able to go out and not necessarily spread the wealth. That's not based on doctors and dollars, that's where my mind goes. But it truly is, I can do it, but do I want to sacrifice my time and do all of this one thing, or could I have somebody else do it? And the same thing, there might be another clinic that is really good at this one thing, but they would love to bring in Dr. Moosavi for at least one day a week, to take some of that load off.
And I still do that. In addition to doing my managing and growing our practice, I still do some consulting at a couple organizations, and it's a great opportunity for us to get involved in that. But yeah, no, I think it's if you don't take advantage of the opportunities, they're just going to pass you by, right? At the end of the day, they're just going to pass you by, and you don't have to let go. I think, and I would be missing a major point here if I don't mention this. But when COVID hit, COVID was a big eye opener for us also. Surgery centers, hospitals, procedure suites, physician offices, patients, everything just kind of went for a dive. And I didn't truly work for about 6 months. So that was another big eye opener, that without your own, patient base, it's a challenge to maintain some type of, income and revenue stream. So that was another big stimulus. But, that was 2020, my push was around 2022. So I did still kind of play at the field a little bit for 2 years, but I still maintain those relationships.
For sure. All right. I'm going to put you on the spot here.
Yeah.
I'm going to have you run down the list of all the lines that you do. Like if you were to look at your week and look at your calendar, let's say it's color coded. It might be I color code my calendar, but you look at all the different lines and all the different specialties that you do. I want you to run down the list, and not necessarily to toot your own horn, because I know you're amazing at each one that you do, but there could be somebody who listens. There's probably somebody that's going to listen to this that is just doing one thing. And they've had that thought of like, what other things could I do within my specialty? Like, yours is PM&R. Maybe there is radiology. There's a radiology practice out there that they're doing one thing. Maybe they're just breast cancer, but there's so many other things that they could be doing. I want you to run down the list just to talk about how you manage your week and all the things that you have going on.
Of course. So obviously the base and foundation is PM&R. So functional medicine, sports medicine, sports injuries. And then we do our interventional traditional pain, and more advanced interventional pain. Again, I took the time to learn some of these advanced procedures. So I focus on that. And I have, even this week, I have a few advanced interventional pain procedures that I do. Orthobiologics is heavy. I love it. I think it's amazing. I see the outcomes. We work with an organization called Regenex that is awesome. They're really good to work with, and we really enjoy that affiliation and a partnership. I do my VA evaluations. Again, it's a great service to offer. We see a lot of benefit to those patients, because they're in need of that kind of care, and it's nice to be able to advocate for them and to be able to support what they're coming to us for, and do my evaluations. I do independent medical evaluations also, which is awesome. Also, and again, I do it for a service because I know patients need certain things and I can help, and or other healthcare organizations need some type of help to help clarify these. So I do independent medical examinations. We do our own in-house pharmacy. I don't do any opiates, just traditional medications that we do, anti-inflammatories, muscle relaxants, etc. And again, it's something that we would have just outsourced, but in coordination with doing our auto, which I do as well as a service line, as well as our workman's comp, so personal injury workman's comp. It's a service line that we can offer, that we can utilize within our scope of practice, but we have that as a partnership, as affiliation. So we don't manage it, we just prescribe, we write it out, but there's someone on the back end that does the billing that's outside of our organization, and we share that. So it's that kind of the adage you mentioned, having a percentage of something and not 100% of it. But because when you take the 100%, you're also taking on 100% of the responsibility, but equally they take on the responsibility. So it kind of is a nice relationship. We also do what's called remote therapeutic monitoring, which is a home monitoring system for our patients. Anyone that's on opiates or medications, they're followed through the month. That we ask them, or a nurse asks them how they're doing, how the medications are working, etc. And they monitor. Are they overusing, underusing? Again, this is a billable service. Medicare approved it a number of months ago, and we offer it. But is it something that we could have offered ourselves? Absolutely. But that would have taken our own nurse, our own staff, our own biller. Instead, we have a partnership with that. So there's an outside company that manages our patients for us, and we have a management service agreement with them, etc. So there's, and so there's probably, those are a lot of our core service lines. Obviously, from a diagnostic point of view, I do EMG, so we get a lot of referrals for EMGs from outside providers, neurosurgeons, foot doctors, other pain doctors that don't do EMGs. They refer these patients to us to do EMGs or nerve conduction studies. I think that covers, for now, the general service line that we offer. If my staff is here, they'll probably lose their minds right now, because it's funny, because when we talk about it, it's so overwhelming, but it's doable. I mean, it's doable. But this is so my week, all of what I just kind of run through, I literally can do all those in 1 week, different days, different times. But again, wearing multiple hats, and I enjoy it. It's variety. It's different. Every patient is different. Every patient has a different need, and I did an orthobiologics consult right before I came on with you, and he was like, "Listen, doc, I don't want pain meds. I just need help. My shoulder's hurting. I need stem cell treatments, etc., etc." So and so every patient is different, and then you have some of the chronically ill patients who we have to manage a little different. But yeah, so I mean, I'm honestly, I'm probably missing one or two. Oh, DME, we do our own DME for personal workman's comp. Again, we could outsource it, but if we have the capacity to service the patient, fit the patient for the brace, and bill for that service rendered, then why can't we do that? I mean, there are certain things that we outsource for sure. Some DME that I don't keep in house: canes, walkers, wheelchairs. We don't do that because that's outside of my scope of practice, or at least specialty. I can prescribe it, but I don't necessarily manage it. But I outsource those things. So it's a combination of utilizing some of the outsourcing methods, but trying to keep a service line and going. And I have a couple more in my head that I'm looking at entertaining. And how do I evaluate? Because this may come up. How do I evaluate if a service line is worth going into? I talk to other physicians who are doing it. Simple. I ask them their experience. How's it going? How's the billing? How's the partnership? If they have a partnership or a management service agreement, how's that going? Does it make sense to you financially? Does it make sense to you staffing wise, etc.? And 9 times out of 10, I'll get enough information that I can make a decision of, do we want to do this, or is it something that I can support my colleague and send it to him or her, and I won't take it on as a service line in my office for my patients. So
For sure, man. A ton of stuff. I mean, variety is the spice of life, as they say.
right,
So I think
absolutely.
that's really awesome. One thing that stood out to me, and it kind of goes there
Yeah,
into your last point, where it's like you are evaluating if a new service line makes sense
yeah,
financially, time management, all these
yeah,
different factors that come into that. One thing that stood out to me is you had mentioned you in-house from a pharmaceutical standpoint, you just have traditional pain medicine. However, you also have another line where you do opiate monitoring. So there's,
correct.
patients have been described an opiate, you provide a service of monitoring that. Was there kind of, just because those are two conflicting things, I mean, we could go talk for an hour about the opioid crisis and everything that went into that.
Right.
And, but what was that analysis like as you're adding in that, hey, we are only going to provide traditional pain medicine to our patients here, but we're also going to have a service where someone else has prescribed an opiate and we will provide the service of monitoring and making sure, within a 30-day time frame. Hey everyone, I wanted to take a moment to talk about what I do outside of being the host of the Doctors and Dollars podcast. I'm the CFO of Grand Vision Capital Group. At Grand Vision, we work with high-income earners who make a great living but still can't quite break through that true wealth ceiling. We utilize strategically chosen investments tailored for high-income earners. The question always at the forefront of our minds is, why wait for retirement to finally live when you can implement an investment strategy that will impact your life today? To be honest, most of the people we work with never even knew these options existed because their financial planner doesn't have access to these exclusive investments. So, if you're ready to finally turn your high income into real wealth, visit our website, www.grandvision.co, and hit the Take Action button in the top right corner to schedule some time with me. Or even better, follow me on any of my social media accounts, shoot me a message. Now, back to the show. They're using that appropriately. What was kind of that dynamic like? What was that evaluation like when you were just deciding to go into those two different factors?
Well, I can tell you that the biggest stimulus behind not doing scheduled medications in our office is from a safety point of view. I mean, there are patients that need even my orthobiologics. When I do my stem cell treatments, PRP, we need to prescribe them something heavy for a couple of days just to keep the pain under control. But that was a choice consciously we made of not keeping those things in our building. We did not want to do that. So that was the primary premise there. When we prescribe, we refer that patient over to our remote monitoring program. And so there's a nurse educator that comes in. So we will prescribe some, I mean, probably maybe 20% of my patients have some type of scheduled medication on board. So we keep that percentage low, and we're probably maintaining that. It's just the patient volume and the referrals that we're getting. But so the answer to your question is we chose not to put anything in house that's opiate related or some type of scheduled medication that can be safety factors, other factors that are involved in our office. And but at the same time, we'll prescribe when it's needed, but we want to make sure those patients are monitored. So it kind of worked hand in hand that we don't want to keep it in house. We don't have a problem prescribing if it's needed, but you know what? If we're going to prescribe, let's prescribe responsibly. Let's send out for urine drug screens, for example, and we don't do that in house. We send all that out. There's certain things I don't have an interest in, or let's monitor them post prescription. Have a nurse follow up with them every 2 weeks, every 3 weeks, or whatever the case is. So that's kind of where that came up. So we're definitely advocates to control pain, and we will do it to the best of our capacity. But at the same time, we want to have patient safety as a marker for our decisions.
Hey, I totally understand. I mean, the first 10 years of my career after college were in risk mitigation.
Yeah, so you probably
for a large bank. So yeah, I'm all about reducing risk.
Yeah.
And leaning out as much as you can just to take that off your table. So I totally get that. I think with the theme that we've had so far as income diversification and providing and offering different lines to all your patients, that's going to attract a lot of people, right? And you and I were talking not just in the Detroit area, but Detroit just in proximity, so close to Canada, specifically Windsor, right across the water there. Is it because of your offering in those lines, or talk to me about what I would call the differences? I'm trying to think of a better word, but the differences in healthcare service that you can offer in the Detroit area and the different lines that you guys offer versus what is being offered and the service provided on the Canadian side.
So a good question. So I can tell you when you compare apples to apples, the services are similar. Epidural injections can happen in Ontario, Canada, Windsor. Treatments, even to some degree, orthobiologics can happen. But the limiting factor here is time. So when you have a patient in pain, when I have an athlete, for example, in pain, and they need an MRI, for example, to get them in to get an MRI done for a pretty established athlete can still take up to 4 weeks. And this is directly from the athletic directors I'm hearing, because I talk to them and we converse, because they're not urgent. Versus if I bring them over to Michigan, see them in my office, do the evaluation, I can get the MRI done in most cases the same day. I'll send them out, they do the MRI, I'll come back, we'll evaluate, make a treatment plan, and we'll move on. Patient moves on, everyone's happy. So it's time, I think. So not so much service line than it is when can you treat the patient. If I get a call from Windsor, Ontario, that's a referral from a colleague of mine in Canada that says, my patient needs an epidural, I can get that patient in within a week, within probably a few days, maybe even same day. Yes, it's a fee for service program at that point. They pay out of pocket for it. But to them, it's peace of mind that, yes, I will spend, X amount of dollars to get myself treated, but I don't have to wait 6 weeks, 3 months, 6 months to get an epidural injection, because that's where we're at right now. And if it's non-urgent, you're looking at, 3 months, 6 months if you're not established with a pain doctor to get just a simple epidural. It's really, really difficult for the patients to do this. And then they get started, then they're prescribed opiates, and they get hooked on opiates, and because they're still in pain, and they have to maintain a daily lifestyle, and so on and so forth. So the biggest differences I find between Canada and the US is time. And they see the difference when they come and evaluate with us. And some of them come and we'll discuss the treatment, and we'll tell them the cost of it, because actually none of them are really insured. And then they'll make a determination: is the cost analysis that they do worth the expense of getting it here, or would they rather wait in Ontario? And I can tell you, probably 50% or more of them come back to us. They're like, you know what? We just found
more
out.
Than 50.
More than 50. We just found out to get that MRI you wanted us to get, and to pay X amount of dollars to get tomorrow, that the earliest I can get it done is 6 weeks in Ontario. They're like, who should we call? And then they call, and then they get it done. Or the treatment, same thing. Like, yes, Ontario, the government covers the treatment, like epidurals, not PRP or orthobiologics, but epidurals, etc. So they're like, same thing, trade-off. Can I come and get it with Dr. Moosavi tomorrow, or should I wait 6 weeks on my scheduled date? I mean, am I going to be in pain in 6 weeks? Is it going to get worse in 6 weeks, and so on? So the biggest limiting factor is time, I find.
Gotcha. And a great answer in that. And I think that a lot of that comes down to, it's kind of behind the curtain, right? That everyone hears, okay, Canada has free healthcare. That sounds amazing. And the healthcare industry.
It does sound good.
Yeah, it sounds great. But like the healthcare industry in the United States, it gets pretty expensive. I mean, health insurance and all those things, it gets pretty costly for the average patient. But we also see that it's very common that a player gets hurt out on the field, has a significant injury, and they're like, all right, well, we'll get an MRI tomorrow just to confirm the injury and set up a plan. Us in the United States, we just kind of think, okay, that's going to happen tomorrow. Yeah. But you're saying in Canada, because of their free healthcare, which is great, that, out of pocket, but the service provided may not happen. That player might get hurt on the field on a Tuesday, and they're not getting an MRI Wednesday. They're getting it in 3 Tuesdays from now, just to confirm that injury, figure out a treatment plan. And in that time, then they're taking pain medication because it's so significant. I guess it kind of opened my eyes a little bit, because you start thinking about Canada. I thought you were going to go like, well, it's free healthcare, and so everyone kind of loves it.
So it's a tough sell, I can tell you, from a business standpoint. To have a patient come from Ontario, do the evaluation with me, I discuss the treatment plan, I discuss the costs of it, and then they kind of look, okay, and on one hand they're holding up the plan of action from our end, and the other hand they're holding up their OHIP card, the Ontario Health Card. Like, should I go down this route, surgery, for example, if we're talking about orthobiologics? I guess I get quite a few orthobiologic referrals. Do I go down the surgical route, which is covered by the insurance, and yes, I'm going to wait 3 months to get my surgery done? Or do I go down orthobiologics, which is not surgical, but costs out of pocket, and so it's I never add stress to the situation for any patient. I lay it out for them. I give them time to think about it. The ones that are interested call us back. The ones, but I invite them to come and do at least a consultation, discuss, talk about it. And we don't have significantly high costs for our evaluations. Like, we keep it very reasonable because I want patients to come in the door and really see what we can offer them, and not get
For sure.
scared off right off the bat, like, oh my God, it's already costing me this much, etc. Because cost factor analysis is huge in patient, unfortunately. So, but
Yep.
rightfully so. I mean, everything's, especially nowadays with how the economy is and the interest rates, et cetera, everything's inflation. So they have to think about a lot of things.
Absolutely. So one thing we've talked about that you've mentioned a lot here is orthobiologics. Relatively new term, right, in the world of healthcare, more commonly known as regenerative medicine. Where do you see the world of orthobiologics in the next 15 years? As you've been able to look back and see, okay, all this innovation that has happened in the last 15 years, what's it going to be like in the next 15 years?
I think it's going to be more apparent, prevalent, recognized. I get referrals. I've gotten a couple of referrals from orthopedic surgeons saying that, this patient's young. I don't want to operate even arthroscopically. Is there a place to do PRP for this patient, orthobiologics? And I do the evaluation. I invite those opportunities. And if I can't, I'll refer the patient to orthopedic surgeon and say, listen, I can't help you. Your degeneration is far gone, past the point where orthobiologics, I think, will help, etc. So we catch both. But I think in the next 15 years, I think we're going to see a huge growth with it. I don't think we're going to lose sight of some of the traditional treatments we do, the surgical interventions, etc. But I think it's nice to have a middle ground now where, if an epidural didn't work traditionally, I would send the patient to orthopedic surgeon, spine surgeon for evaluation, and they have a laminectomy, discectomy. But now, maybe we can try a regenerative route. Maybe we can try some type of orthobiologic route and see if that could help. And then if it doesn't, we still have the option to go for surgical intervention, because what we do orthobiologic wise really doesn't create any problems for the patient. It's really a matter of whether it helps or not. And that's the beauty of it, right? But I think there's going to be a lot of growth. I think there's going to be a lot more interest. Patients are coming to me. When I see my orthobiologic consultations, I can tell you 75% of them come in already knowing what they want,
Really?
Bone marrow concentrate, PRP, I want it here, I want it there, et cetera, et cetera. And they come with a slew of questions, and they're educated. And I think that education, that awareness is going to spread. So a lot of my talks I do, lectures, small group sessions, journal clubs, et cetera, I do discuss orthobiologics as a part of it, not strictly as a part of every single, sit down, but I do for a fair bit, because I want referring sources. I want physical therapists, chiropractors, whoever I work with, other physicians, to understand what it is and to see the benefit in it, and I've had personal benefit of observations within my family, my colleagues, my parents. They've all gone through orthobiologic treatments, and they're doing fairly well.
So just my naiveness, what is PRP?
Platelet rich plasma. So it's the product that we prepare, whether it's through extraction of the vein or whether it's through extraction of the bone marrow concentrate, we still can prepare these platelets. So a solution basically filled with platelets, high concentration of platelets.
Gotcha. The advancement there has got to be, I mean, that probably wasn't something, let's say even back in the 90s or early 2000s, that probably wasn't something that was super relevant. The other thing I think of that might not have been was stem cells. Talk to me a little bit about how stem cells work. I mean, you say patients come in very educated and they're doing all this research. Not something I've done research on, just because I don't feel like I've needed it. But tell me a little bit about stem cells and the advancements that you see there.
And again, we're talking about bone marrow, right? Bone marrow concentrate is where we kind of extract some of these mesenchymal, some of these, stronger, more potent cells, right? This is where we get it from. And, like today I did a consultation. The patient came in and said, Dr. Moosavi, I want bone marrow. I want stem cell. So I explained to him, and believe it or not, we went through the whole consultation. I usually spend about an hour with each patient just to educate them, get their feedback, examine, ultrasound, etc. And at the end, we determined that maybe stem cell may not be the best. I told him, I think PRP, the venous draw, the straightforward traditional treatments that we use, maybe adequate enough for him. And he was in shock. He's like, but doctor, I really want the stem cell. I said, you can do it. It's totally up to you. You're the one that's paying for the service. But I think there's an adequacy. So we make that evaluation, but some patients come in because they read up on it, they know the potency. So if a patient comes to me and says, Doc, this is what I want, if it's not contraindicated, I don't have a problem doing it. But I also give them kind of like the truth, or the understanding of what I think is enough for them. But that's what happens. It happens a lot. They're very educated, and and so when it comes to stem cell, there's a lot of awareness. There's a lot of research out there. There's a lot of bone marrow concentrate injections, BMAC. There's many like terms that are coined for that type of intervention, and then I think they're going to continue doing more and more research on it.
For sure. So on the flip side of that, because what you do is very reactionary, right?
Yeah.
Somebody has pain, they've had an injury, you're coming in and creating a plan there.
Right.
In an earlier episode 4, I had a chiropractor on the show who focuses a lot on mobility, focuses a lot on injury prevention, right? A chiropractor will. So a lot of what you do is reactionary, right? Somebody has a sports injury, they've had pain in their shoulder, they finally, as a reaction, they come to you for treatment. Back in episode 4, we had a chiropractor who focuses a lot on mobility and injury prevention, and talking about some of those things. Where do you see advancements in injury prevention happening? But also, do you see your practice evolving in a way that you're also providing education or maybe even services that are more focused on injury prevention versus injury reaction?
Very important. Injury prevention, rehabilitation, protection. I see a decent number of athletes. A lot of them are football players, some soccer players, a couple of runners. So, they come to me, a lot of them come to me for orthobiologic evaluations, but in addition to the discussing that, we also talk about, okay, so if we're going to do this, how do we prevent it from happening again?
Sure.
The injury again, et cetera, et cetera. So awareness, I think, is just as important. I mean, I would feel, happy and content if a patient comes to me and I do an evaluation, I deem them not necessarily a good candidate for it, but I educate them and say, hey, listen, if you do A, B, C, or D from a rehabilitation point of view, I think you'll be okay. I think, we'll follow up with you in 6 weeks and we'll see how you're doing. So definitely prevention, 100%. Awareness is just as important, and post-treatment correction of lifestyle behavior. Especially in the world of orthobiologics, because I'm like, the last thing I want to see you is back to me in 6 months because you re-injured the same area. I mean, I treat jiu-jitsu fighters who have MCL tears, and I got a guy came in who was an LCL tear. We treated it with bone marrow, did amazing. He came in because we thought his MCL was torn because he injured the other knee. Did an MR, didn't find pathology, there's some inflammation, and I said, you know what, let's physio. Let's not do orthobiologics. I don't think it's necessary at this point. Let's do some physiotherapy, some strengthening, et cetera, et cetera. Education, awareness, and he's a young guy. And could I have said, hey, we could try the PRP and see what happens? Absolutely. But I felt the advantage for him would be more education and awareness and training and recovery and rehabilitation. So I definitely focus on that, and I think there's going to be a huge push towards that.
Yep, I had to ask you that. Mutual friend of ours, Dr. John Santa Ana, I had hit him on episode 2, I believe.
Okay.
And asked him the same thing because of what you do, PM and R, right? Rehabilitation is truly part of what you do, and I wholeheartedly agree with what you just said. Is that rehabilitation can really also be, how do we not? It truly can be prevention as well, so that the injury doesn't happen again. And you might not know this percentage off the top of your head, but what do you think the percentage is of people who re-injure the same joint, the same ligaments again because their rehabilitation or their prevention, they didn't do a very good job with it?
The percentage is not that high. I wish I could give you a specific, but if I see a patient come in for a repeat treatment, it's usually often after a number of years, 1, 2 years, 3 years, because the treatment we did helped them. But I also tell them, I said, listen, you have a disc herniation, you have, okay, whether we do orthobiologics or traditional pain, you still have that condition. We're fixing the problem to some degree in terms of controlling the pain, reducing the inflammation, repairing, restoring, etc. But you still have an underlying issue. So, if I do this, I don't want you, going bungee jumping tomorrow, right? It doesn't make sense. So even if you feel good, so that part of education is huge because we see that all the time where I see patients get really good, and runners, for example, and they get back in and they're half marathoners or they're full marathoners, and I do the treatment. We do like a gastro tear, we do some regenerative treatment on them. They do awesome, and I say, listen, taper yourself back into it. Don't just go off and run a half marathon. You're probably going to tear that again, or you may re-injure, strain it, etc. So that's a really important education aspect of it. Yes. But I don't see too many come back with recurrent injuries because I think we focus on that. We send every patient home with kind of a spreadsheet of how we want you to recover. We recommend that you recover. None of it is bed bound or limited in terms of activities. We want to and encourage functionality, but we still give them a guideline. So we try our best to treat and educate, and so hopefully we don't see them again.
It's awesome. Well, for everyone who's listening that's in the Detroit area, obviously go to Macomb Pain Management, soon to be Macomb Orthobiologics. I think that term is going to get coined. It's going to catch on. Regenerative medicine is going to be kind of remember back when in the 90s when we said regenerative medicine? Now it's orthobiologics. Right. I think that's awesome. But it was a pleasure having you on today. I'm glad you took some time out of your, as we know, busy day that you had to spend it with me.
Appreciate it. And just to kind of clarify, so our primary practice is Macomb Pain Management, and yes, our orthobiologic line is Macomb Orthobiologics. And so
you'll have a line, okay?
Yeah, and different. There's different websites for each one. So MacombPainManagement.com and MacombOrthobiologics.com. So
awesome.
Check us out. We'll be happy to at least even entertain the consultations, open discussion. We give each patient a good amount of time to come in and talk to us, and answer as many questions as we can.
That is great. Well, I appreciate your time. Wishing you the best, Dr. Moosavi.
Appreciate it. Take care. Have a nice evening.
You too. Hey, everyone. As we wrap up today's episode, I want to talk about the second opinion. As most of our listeners are physicians, you guys know the importance of having another medical professional's insight for a patient's treatment plan. But have you ever considered having a second opinion on your financial plan? Or have you simply trusted your financial advisor episode, they've already leveraged every strategy that your family needs? Most of our listeners are physicians. 100% you guys know the importance of having another medical professional's insight. That's why for my doctors and patients listeners, each Wednesday, have you ever considered having a second opinion on your financial plan? Provide a free second opinion. Or have you simply trusted your financial advisor during this hour? They've already evaluated your financial goals and your family needs. Will ensure tax mitigation strategies are in place to meet your financial goals. And ultimately, give you confidence. That's why for my financial outlook listeners, because that each Wednesday I block off 3 time slots, an hour each, to provide a free second opinion of their financial. These 3 spots each Wednesday during this hour will reevaluate your financial goals and your risk tolerance, ensure tax mitigation strategies are in place, and ultimately give you confidence with your financial outlook. Because that is what drives a happy home, a quick form about you, a happy marriage, schedule a time for us to meet. Thanks for tuning in. These 3 spots, I hope the rest of your week do fill up fast. Cheers. Send me an email at nate@grandvision.co or head over to www.grandvision.co/second opinion to fill out a quick form about you and schedule a time for us to meet. Thanks for tuning in, and I hope the rest of your week is abundant. Cheers.